Hello, and welcome to this presentation, Understanding the Illicit Drug Supply Through Xylazine. My name is Jordan Wulz, and I am an associate professor with Concordia University, Wisconsin School of Pharmacy. Overdose deaths from illicit drugs have consistently risen each year since 1999, with some of the most exponential increases occurring over just this past decade. In fact, drug overdose deaths have doubled from around 50,000 in 2015 to 110,000 in 2022. This presentation is a story of how this has happened and why the emergence of xylazine in the illicit drug supply is a warning sign for the continuation and even potential worsening of our ongoing drug overdose crisis. I have no financial relationships to disclose at this time. In order to tell this story, we will have to understand what the current state of the illicit drug supply looks like in the US, as well as what we can expect moving forward. Additionally, we will focus in on xylazine as an emerging threat and discuss various pharmacologic properties of the drug, in addition to how to manage overdoses and withdrawal syndromes. Lastly, we'll discuss harm reduction strategies that can be incorporated into our practice now, as well as explore strategies that may become necessary as the illicit drug supply continues to evolve. The social cost of drug overdoses and deaths is well known and documented. Families and friends have lost many loved ones to drug use. Drug users have been cut off from society and suffer increasingly varied health issues beyond overdose, including HIV, hepatitis C, endocarditis, and other superinfections. Our historic and current national drug policy is to punish drug users with felonies and jail time for possession, despite evidence that addiction is often a lifelong, remitting, relapsing disease, and despite the stigma that accompanies incarceration. This has led to downstream effects that damage drug users' ability to recover and rejoin society, including difficulty with finding consistent work. And beyond the social cost is the financial cost. And it's important to understand there is an underground economy that is ultimately dependent on the illegalization of drugs. Between 2006 and 2016, Americans spent close to $1.4 trillion on illicit drugs. That's big business. And it encourages illicit drug manufacturers to continue to develop drugs that have become increasingly more toxic. For example, federal sanctions on fentanyl importation has led to an influx of fentanyl analogs with just a few chemical changes that skirt the law and, more importantly, increase the potency and toxicity of the substances. The book Fentanyl Incorporated details how these sanctions led to Chinese companies marketing fentanyl and fentanyl analog precursors for sale in the US. And when there's this much money involved, illicit drug manufacturers really are not deterred by legislation. And this has directly led to a more complex and dangerous drug supply. To date, it has not decreased the amount of fentanyl in the drug supply. And we shouldn't forget also that illicit drug supply is big business for legal entities. Whole divisions of the FBI, the DEA, and the criminal justice system are built around seizing illicit drugs and prosecuting users and dealers. So we're talking about a lot of jobs that are directly maintained by this illicit drug supply. As pharmacists, it's important for us to understand the contribution of prescription opioids to our current crisis. Again, it's been well documented that overprescribing of opioids for pain did lead to increasing rates of addiction. So when the CDC guideline for opioid prescribing was published in 2016, opioid prescriptions started to plummet. In 6 years, we saw almost 100 million drop in prescriptions for opioids from 250 million to 150 million. And this was an explicit goal of many opioid stewardship programs, as well as the DEA, and has been applauded in the media. But did that make a difference in reducing opioid overdose deaths? Another way to ask the question, were opioid prescriptions the primary driver of opioid deaths? It's difficult to say, with the influx of fentanyl occurring around the same time point, but it's an interesting philosophical mental exercise to consider whether those addicted to opioids were better off with consistent regulated supply under the care of healthcare professionals compared to those who were forced to taper and engage with the unregulated and toxic street supply. And it remains to be seen if this system-wide approach to opioid prescribing will eventually lead to less addiction and subsequently less overdose deaths. But in the meantime, some might say we created a whole new crisis of our own making. And those who engage the illicit drug supply, even if they don't suffer from addiction, and even if they don't think they're using opioids, are at a much higher risk of death due to the evolution of the drugs that can be obtained illicitly. These next few slides will focus on the story in Ohio, described by the organization Harm Reduction Ohio. Historically, heroin or diacetylmorphine has been the primary opioid in the illicit drug supply. Over the last 10 years or so, however, that has changed drastically, with only 3.6% of the drug supply in Ohio being heroin in 2023, as compared to 33.5% in 2015. This has major implications for drug users, namely that buying heroin isn't really buying heroin anymore. Drugs being sold as heroin more than likely are not actually heroin. Chronic users who previously knew how much drug volume they need to achieve euphoria or avoid withdrawal no longer have that luxury. And in concert with the reduction of heroin, Ohio also saw a significant increase in fentanyl or its analogs, ultimately replacing heroin in the illicit drug supply. Now users are having to contend with an ultra-potent opioid whose potency can vastly vary depending on its chemical structure, again, without really knowing what they're buying. For those engaged in the war on drugs, eliminating heroin from the drug supply most likely would have been seen as a win, but unintended consequences often lead to even worse outcomes. In this case, a relatively consistent opioid drug supply has become infamously inconsistent and much more toxic, directly leading to unprecedented increases in drug overdose deaths. And this, of course, doesn't apply solely to the opioid drug supply. A lesser known consequence is fentanyl being found in other non-opioid drugs. In 2023, almost 20% of the cocaine supply in Ohio included fentanyl. Inherent in the nature of an illicit drug supply is a lack of consumer protection. Drug users don't get neatly packaged products that tell you what they're buying, or the dose, or the concentration of the drug. They certainly don't get directions on how to use the drug, and package inserts are all but unheard of, tongue in cheek. There's little legal recourse for bad batches, and users who think they're buying cocaine from fentanyl overdose. They don't think that they need naloxone on hand, and they certainly aren't seeking out MOUD treatment because they don't think they're using opioids. Cocaine and other stimulant use is on the rise and is a significant risk factor for opioid overdose death. Compared to opioids, cocaine use is more likely to be used on an occasional or social basis, putting users at an even higher risk of death due to a lack of tolerance to opioids. And of course, fentanyl isn't the only drug infiltrating the illicit supply. Overdose deaths are no longer easily qualified into distinct drug categories. Part of this is the rise in polysubstance use, but that polysubstance use is becoming increasingly unintentional. There are a number of organizations that offer drug testing services for those using illicit drugs, and they'll often publish alerts based on batches, specific geographic area, as well as results from single samples. Drugstested.com is one of those resources, and as an example, one of the single samples they tested included 11 distinct drugs for the sample that was supposed to be heroin. This included caffeine, procaine, clonidine, tramadol, fentanyl, xylazine, tetracaine, acetylcholine, fluorofentanyl, 4-ANPP, and yes, some heroin as well. And the study you're looking at here tested for drugs detected in residue samples from drug paraphernalia in Maryland. As you can see, fentanyl is the primary drug found in these residues, but close behind was xylazine, confirming that xylazine's prevalence in the drug supply is becoming more prominent and something we need to prepare for. Ultimately, it's too simplistic to say that we're dealing with a fentanyl problem. We're dealing with a drug transparency and toxicity problem. This is an example of one of the drug alerts from getyourdrugstested.com, which they post on their Facebook page as well as their website in an effort to alert drug users to potentially dangerous drugs. This sample is from 2022 in Canada, where a user thought that they had bought ecstasy. What they had received actually had no MDMA and was in fact 75% fentanyl. This illustrates the increasing risk of casual or social illicit drug use, especially in the music festival scene. In fact, one harm reduction organization called Dance State sets up booths at major music festivals across the US for this exact reason, and they offer drug checking services and non-judgmental education about drugs to attendees. So what do we learn from all of this? There are still many unknowns about our current drug crisis, and there are certainly a variety of opinions on how to best approach the issue. But what's not up for debate is the evolution of the illicit drug supply. What started as primarily a heroin issue has developed a polysubstance issue with previously unheard of drugs in the illicit supply. Heroin has led to ultra potent fentanyl. Fentanyl has led to even more potent fentanyl analogs. Fentanyl and its analogs have led to xylazine. We'll talk about why. And now we're starting to see a new class of opioids infiltrate the drug supply, namely the nitazines. The question of what's next in the illicit drug supply is not a question of if, but rather when. And if this recent history is any indication, the next drug may be worse than the one before it and may lead to difficult complications, as we've seen with xylazine. More to come on that. Let's take a look at some data that is a little closer to home. These graphs are from a CDC article on xylazine-related deaths in Cook County, Illinois, otherwise known as Chicago. As you can see from the graph on the left, xylazine-related deaths were non-existent in Chicago up until October of 2018. And while these numbers remain small, there's an obvious upward trend that correlates with the percentage of fentanyl-involved deaths on the right. In fact, fentanyl was also essentially existent up until October of 2018. What we're seeing is xylazine becoming a more common component of the opioid drug supply, which indicates we have to be considering what that means for drug treatment and harm reduction services. So what is xylazine anyway? Its legal use in the US has been restricted to veterinary medicine, where it's indicated for procedural sedation in large animals as a result of its mechanism as an alpha-2 adrenergic receptor agonist and resultant inhibition of norepinephrine and epinephrine release. In the US, it's commonly referred to as tranq by drug users, a reference to its original indication. Originally studied in the 1960s as an antihypertensive agent for humans, similar to clonidine, but was determined to cause severe CNS depression, making it inappropriate for human use. As we've discussed, it is most commonly found in combination with illicit opioids in the drug supply and has not been considered a traditional opioid. However, recent preliminary research has identified it may agonize the kappa opioid receptor. And kappa receptor agonism can also lead to pain relief, but additionally dysphoria and sedation, and that's seen also other kappa opioid receptor agonists like levorphanol and pentazocine. So understanding other mechanisms of action for xylazine can help inform potential treatment options for overdose and for withdrawal symptoms. But why did xylazine find itself in the illicit drug supply in the first place? With the influx of fentanyl as the primary opioid in the drug supply, xylazine found a role in increasing the duration of euphoric and sedative effects of opioid use. Fentanyl and its analogs are known to have a short half-life and limited duration, which really make it a useful tool in the critical care and procedural setting. But for drug users, this can be perceived as a negative chemical property. So xylazine was introduced to help give fentanyl legs, and additionally, may also help delay opioid withdrawal symptoms between doses, similar to how clonidine is being used for opioid withdrawal symptoms. So xylazine was first identified in the drug supply in the late 80s in Puerto Rico, where it was referred to as anesthesia de cabal. caballo. I'm not a native Spanish speaker, so please forgive my pronunciation there. But what that means is horse anesthesia. And since then, it has traveled to mainland US and was first identified in 2006 in Philadelphia. The Northeast was the earliest mainland geographic area to be hit with xylazine, with Philadelphia often considered as the epicenter of the crisis. For example, from 2015 to 2019, Philadelphia saw an exponential increase in drug overdose deaths that involved xylazine from 2 to 31%. And as of 2022, 34% of all overdose deaths in Philadelphia involve xylazine. In animal studies, xylazine has been observed to be quickly absorbed. As a result, the drug works quickly with a time to effect of 1 to 2 minutes, and it has a large volume of distribution due to its lipophilicity, and it's rapidly concentrated in the CNS and kidney. Xylazine is metabolized by CYP enzymes in the liver and excreted through the kidney, and its metabolism is rapid. It's quickly eliminated from the body with a half-life of 23 to 50 minutes, which has implications on screening for the drug in the emergency setting. But despite this rapid elimination, a therapeutic effect of sedation can actually last between 4 to 8 hours, again, having implications on overdose reversal, especially when compared to fentanyl. The pharmacodynamics are especially important to understand. Xylazine stimulates central presynaptic alpha 2 receptors with high affinity, which then depresses the sympathetic nervous system and decreases the neurotransmission of norepinephrine and dopamine. So, what does this mean for the human experience? Well, the primary effect is sedation, but it can also cause hypoxia, bradycardia, and hypotension. However, as seen with abrupt discontinuation of clonidine, it's also possible to see rebound hypertension, which again has implications for reversal agents. Hyperglycemia has been documented in animal studies as a result of decreased insulin release and sensitivity, and acutely it may also cause hypoglycemia. Since xylazine can reduce the level of consciousness in addition to its other sympatholytic effects, the risk of opioid overdose and death is increased in combination with heroin or fentanyl. Similarly, it may prolong the duration of the overdose, which can make reversal efforts more difficult. On its own, xylazine is not likely to lead to a fatal overdose. In fact, in overdose deaths involving xylazine, fentanyl, or its analogs were identified in 98% of those fatalities. But xylazine has also been associated with severe necrotic skin ulcers and wounds. And what distinguishes this effect from previously documented skin and soft tissue infections from IV drug use is that these wounds can occur at sites beyond those used for injection. IV drug users are at an already high risk of bacterial infections at the site of injection, often due to the introduction of bacteria from the injection itself. But xylazine wounds can occur outside of that initial injection area. These wounds typically start off as a cluster of small holes, which eventually develops into a single large wound. These wounds, of course, are at a high risk of infection, but are not necessarily infectious by nature. The mechanism for these wounds is still unknown, but it's theorized to be related to xylazine's vasodynamic effect of vasodilation and vasoconstriction. Consequences can potentially lead to decreased skin perfusion and the development of skin ulcers. And this is supported by the fact that these wounds can occur regardless of the route of administration and remotely from the injection site. Now, a bit of a warning here for those who may be a bit squeamish. The next slide does contain photos from some case report of xylazine-induced skin wounds. The wounds depicted here are at advanced stages and may not immediately present as such, but given the often chaotic lifestyle of chronic drug users, they may not seek medical attention until the wounds have gotten out of control. Xylazine wounds can appear quite dramatic, but they often respond appropriately to wound care over a longer period of time. Xylazine wounds should be consistently cleansed with soap and water or saline solution by the individual. And it's important to educate individuals they should not use hydrogen peroxide on the wound, as this can actually delay wound healing. Medical grade honey, such as Medi honey, can also be used by the individual to debride dead skin tissue. And the individual should also be advised to avoid picking at the skin to prevent infection. In the medical setting, clinicians should assess the wound for signs of infection, such as erythema or purulence, as well as systemic signs of infection. The wound can be debrided with agents such as Santyl or Dakin's half strength. And additionally, antimicrobial agents such as chlorhexidine, acetic acid, mupirocin, or silver sulfadiazine can be applied to the wound. The wound should be dressed with non-adherent material and should be redressed frequently to avoid continual bacteria growth. In some cases, it can be helpful to incorporate skin grafting of the wound with synthetic dermal substitutes, but it should be noted that this can actually put an individual at a higher risk of systemic infection if they're still actively using. It's also important to recognize that xylazine does not have an approved reversal agent for humans. And it's equally important to recognize that reversal agents are not always without risk. For example, we know that administering flumazenil for benzodiazepine overdose can lead to seizures and potentially death for those with a physical dependence. In the case of xylazine, acute reversal could lead to potentially severe hypertensive emergencies through rebound hypertension. On the other hand, we're aware that overdose deaths with xylazine are closely correlated with fentanyl use and subsequent respiratory depression. So one of the most important steps in managing a xylazine overdose, in addition to other standard opioid overdose reversal treatment, is administering naloxone, despite the fact that it will not directly reverse xylazine-related sedation. As it relates to opioids, there are important distinctions between acute intoxication and overdose. The primary goal of overdose reversal is to restore respiratory and cardiovascular function, not necessarily waking up the patient. This is especially important in the context of xylazine and opioid overdoses, since sedation from xylazine is not likely to be reversed by naloxone. So using wakefulness as a therapeutic endpoint can lead to excessive naloxone dosing, leading to undue opioid withdrawal. There's been a lot of talk in the media about naloxone-resistant overdoses, which may be a misunderstanding of xylazine opioid combinations. It may appear, based on wakefulness, that the overdose is resistant to naloxone if xylazine is also present. But naloxone is very effective at displacing fentanyl and its analogs from opioid receptors, so we should be focusing on return to normal respiratory function, an indicator of effectiveness. The following are action steps to take for lay people responding to an opioid overdose, should they be in a position to help, and apply similarly to an overdose that involves xylazine. Individuals should always call 911 first. Emergency personnel have naloxone on hand and they're skilled in cardiopulmonary resuscitation if needed. This becomes especially pertinent for opioids that have a longer duration of action than naloxone. Naloxone should then be administered, which may allow the individual to spontaneously start breathing again. But if they do not, it's important to provide rescue breathing, which can easily be administered by a bystander. First, we recommend checking inside the mouth to make sure there's no airway obstruction. Then they can tilt the head back, lift the chin, pinch the nose shut, and deliver 2 breaths into the mouth with 1 breath every 5 seconds thereafter. Lastly, it's important to remind the bystander to put the patient in the recovery position and stay with the patient until help arrives. An emerging complication of xylazine in the illicit drug supply is difficult to treat withdrawal symptoms. Chronic users can develop a physiologic dependence to xylazine similar to that seen with opioids. Opioid withdrawal is notoriously difficult to manage and is a significant factor for continued use. Adding xylazine to the mix can make this even more difficult, and may delay or prevent drug users from seeking treatment programs. Xylazine withdrawal can also lead to medical emergencies as a result of hypertension and tachycardia. Other symptoms are similar to opioid withdrawal, including anxiety, diaphoresis, restlessness, and agitation. Symptoms can last several days to several weeks. In addition, these symptoms are unlikely to improve with standard opioid withdrawal treatments such as methadone and buprenorphine, since xylazine does not have mu opioid receptor activity. This too can inhibit successful induction into MOUD treatment programs. So if what is thought to be opioid withdrawal does not improve with MOUD, we should be considering if xylazine withdrawal is contributing to persistent symptoms. There are no FDA-approved agents for xylazine withdrawal, but case reports have shown benefit with commercially available alpha-2 adrenergic agonists such as clonidine, tizanidine, dexmedetomidine, and guanfacine. These agents can, of course, also help with the opioid withdrawal symptoms. In addition, with the potential for xylazine to be a kappa opioid receptor agonist, butorphanol, pentazocine, and nalbuphine may be important treatment options in the future. Other agents that have been used for xylazine withdrawal include ketamine, gabapentin, and pregabalin, as well as benzodiazepines. And while xylazine has received the bulk of the attention, it's important to keep our eye out for the next new thing. The nitazine group of opioids were developed in the 1950s as analgesics, but were never approved for human use. Their appearance in the illicit drug supply may be a result of governmental actions related to fentanyl and its analogs. Since drug laws in the US are based on specific agents, illicit manufacturers are continually seeking novel psychoactive agents whose legal status is not well defined. The DEA has since scheduled a variety of nitazines, but the creation of analogs via chemical tinkering remains a very real possibility. The problem with the introduction of novel psychoactive agents into the illicit drug supply is that we often have little information on the pharmacokinetics and pharmacodynamics of such drugs, as we've seen with xylazine, making the argument that banning or scheduling drugs potentially worsens the overall drug crisis. What we do know are the nitazines are extremely potent and carry a high risk of overdose, even in those who have developed tolerance. Brorphine, similarly, is being identified more frequently in drug tests and autopsies. And of course, fentanyl analogs have not slowed down, with many carrying a higher potency than fentanyl itself. In the context of addiction, abstinence is not always possible or even desirable by an individual. Similarly, our MOUD treatments are limited and often have significant barriers, even with the removal of the X waiver for buprenorphine prescribing. Outside of the context of addiction, casual or occasional use can be deadly, regardless of the drug used, because of the toxic drug supply. Thus, we need to consider how to reduce harm from drug use, even if we don't want individuals to use. There are a number of available strategies for harm reduction that you can start incorporating into your practice and patient education, including encouraging individuals to never use alone. This isn't always practical, so a nonprofit called Never Use Alone developed a 24/7, 365 days a year hotline for drug users to receive non-judgmental support over the phone and to help alert emergency services if the caller becomes unresponsive. As pharmacists, we can also help train drug users and their family or friends to carry and use naloxone when necessary. As many of you are aware, under the statewide standing order, we can also dispense naloxone without a prescription, which remains important despite its over-the-counter status because of insurance coverage. Like fentanyl before it, there are now commercially available xylazine test strips. This is an important tool, but its limitations must be recognized. The test only detects the presence of xylazine or fentanyl and does not describe concentration or dose. In addition, in some geographic areas, most illicit opioids are now primarily fentanyl, so a positive test may not stop an individual from using, but they may use less as a result, which is also a harm reduction strategy. Needle exchange or provision remains an important strategy for those who inject drugs in an effort to reduce the transmission of HIV or hepatitis C through used needles. Pharmacists in the community or hospital setting can provide unused needles and syringes to active drug users without intent to stop. And lastly, we can educate individuals on safer use practices. To avoid infection, users should be educated to avoid injecting into or near wounds. And for those with difficult to access venous sites due to scarring or xylazine related wounds, subcutaneous or intramuscular injection may be preferred to prevent injecting into or near that wound and prevent injection into central veins, which can lead to vessel and nerve injury. Some harm reductionists have also advocated for non-injectable use as a safer practice to avoid infection with xylazine wounds, and this would include smoking, insufflation, or rectal administration. Though this still might not prevent wounds from occurring in the first place. Other harm reduction strategies that have been implemented include providing a safer supply of illicit drugs. We know that one of the major issues with the illicit drug supply is that it's inherently unregulated and infiltrated with known and unknown adulterants, which are ultimately leading to overdoses and deaths. So what if we did have a safe supply available for individuals who use drugs? What if we could get rid of testing altogether and simply provide a regulated supply? One community organization in Canada called the Drug User Liberation Front, in an act of civil disobedience, buys illicit drugs off the black market, tests them for purity, and provides them to drug users at cost to prevent predictable overdoses from the unregulated supply. This may sound radical, but some would say that we already have a safe supply in the US with methadone and buprenorphine, both of which unfortunately are plagued by access barriers. Overdose prevention centers or supervised sites are another strategy implemented in Europe and Canada for some time, and more recently in New York as of 2021. Overdose prevention centers offer safe, clean spaces for people who use drugs where they can access clinical care and other harm reduction services, such as drug testing, needle provision, naloxone, and referral to treatment. And of course, they're also able to use their drugs on site where people are standing by with naloxone. These centers essentially combine naloxone access, drug testing, and needle exchange strategies into one building. The data from New York's first year, from 2021 to 2022, indicated they had over 2,000 participants, 48,000 uses of the facility, 633 overdose interventions, and most importantly, 0 deaths. But they rightly point out this does not mean that all people who use the overdose prevention center did not die. During the hours they're closed, drug users are relegated back to the streets without any of the same safeguards, and unfortunately, some have died from overdoses outside of the facility. Decriminalization and legalization are topics that are difficult for Americans to envision, given our longstanding punitive drug policies. But as the opioid overdose crisis worsens, some are starting to question the effectiveness of such an approach. In other words, does banning drugs work? It's a difficult question to answer, but what we do know is that it has led to more potent drugs in the illicit supply, some with even more harmful consequences. Portugal decriminalized drug possession in the year 2000, and Oregon followed suit in 2020. Though it seems like they are likely to overturn this in the upcoming year due to political pushback. Decriminalization is advocated to decrease the negative consequences of criminal penalties and incarceration that prevent drug users from easily rejoining society upon recovery. Additionally, it's thought drug users will feel less shame and stigma related to their use and may be more likely to seek medical help. In fact, just this past year, the American Pharmacists Association passed policy statements in support of decriminalizing personal possession or use of illicit drugs. And finally, some harm reductionists think the best answer to the crisis is legalization and systematic regulation of currently used illicit drugs. This is another form of ensuring a safer and predictable supply without adulterants. And it's obviously a politically polarizing topic that we've seen play out even in our own state with cannabis, and likely would be even more so when discussing legalization of stimulants and opioids. So, what can we learn from all of this? Well, we know the illicit drug supply will continue to fluctuate with novel psychoactive substances entering the supply each year. This makes combating the opioid crisis even more difficult. Xylazine is certainly the newest drug infiltrate with the most attention right now, but it likely won't be the last. Xylazine compounds opioid addiction and overdose management due to its own withdrawal syndrome and risk of skin necrosis. But as pharmacists, there are a number of strategies we can implement right now to help our patients understand the drugs they're using and how to reduce the risk that accompanies this drug use. Where harm reduction goes in the future is anyone's guess, but there are existing arguments and examples for even the most radical ideas. In conclusion, thank you so much for attending this webinar on the illicit drug supply through the lens of xylazine.